Good afternoon, everyone, and thank you very much for being here today. I am Ryung Suh, President-elect of the American College of Preventive Medicine, and I'd like to thank all of you for taking time out of your busy schedules to join us. I'd like to particularly thank our ACPM Prevention Alliance members for their support of the college and our mission. I also want to welcome our past presidents and members, including our newest classes of ACPM fellows who will be joining us today. We've expanded today's meeting and invited those from the ACPM membership who have a special interest in HIV treatment and prevention. And we are excited to share this presentation with you and to provide an opportunity to connect with so many other leaders. As a ACPM partner, fellow member, and alliance member, you are making a commitment to advancing prevention and improving population health through shared values, mission, and activities. The ACPM Prevention Alliance is positioned to help transform the healthcare system through the power of prevention and to improve the health and well-being for individuals, families, and communities. We can witness the breadth and depth of this group, which includes technology companies, biopharmaceutical manufacturers, academic institutions, physician networks, health and wellness companies, and nonprofit organizations. The ACPM initiatives and reach of the past few years truly represent the importance of the Prevention Alliance and the role it plays in helping the college achieve its mission. We make it a priority to provide you with a platform to exchange knowledge and to engage with leaders and members in our specialty and with other industry partners. And your participation today is essential to the strategic direction of the organization. So thank you again. To introduce the topic and the speakers for today's conversation, I welcome ACPM's very own Chief Executive Officer, Donna Grande. Donna?
Hi, thank you, Dr. Sun. Thank you so much for carving out the important time out of your very busy schedule to be with us just at the start of the program. I know you're unable to stay with us for the whole program, but I know that you're here with us in spirit and your leadership with the college. So thank you so much. I am so pleased that everyone could join us today on this 35th World AIDS Day. It was established back in 1988, over 35 years ago. It's hard to believe that any of us were around 35 years ago, but 35 years ago, many of us may still remember when this launched, and to raise awareness of HIV and the continued need for preventive services. The theme of today's World AIDS Day in 2023 is called World AIDS Day 35, Commit and Remember. This convening of ACPM's mission-driven partners is part of ACPM's commitment to address prevention and the persistent stigma around HIV. While major advances have taken place in HIV prevention and treatment, there's been an overall decline in the rate of new HIV infections and an increase in the quality of life for those living with HIV. However, we also know that an estimated 1.3 million individuals worldwide and approximately 32,000 people in the United States acquired HIV in the years of 21 and 22. We also know that there are demographic and geographic distribution differences of new infections, and access to preventive care and treatment options are demonstrably unequal and disproportionately impact minoritized populations. While preventive medicine has an important role to play, not only in leveraging our critical scientific advances in HIV prevention, diagnostics, treatments, and outbreak management in general, but also in bridging the equity gap in terms of who has access to preventive and/or therapeutic HIV care. We hope that each of you will engage with us today, this afternoon, in a robust discussion on current efforts and opportunities for preventive medicine physicians to help end the HIV epidemic. Now, to provide a snapshot of what ACPM is currently doing to promote HIV prevention, I'd like to introduce you to Meera Agneswar, who's one of our program managers at ACPM, on the ACPM program that we've been working on with the Centers for Disease Control on partnering and communicating together. It's an initiative to broaden the reach of HIV prevention tools and messaging. Meera is a program manager, as I mentioned, with ACPM, and she's responsible for supporting our grant work and planning and implementing this project deliverables funded by CDC. She's passionate about infectious disease management, emergency preparedness, health promotion, and health communications. And we're so thrilled that Mira joined our ACPM team after earning her Master's of Public Health from the George Washington University here in our backyard in Washington, D.C. So Mira, we're going to hand it over to you to take it away to share and showcase the work that we've been doing at ACPM.
Great, thank you, Donna. So like she's mentioned, I will provide you all with a summary of our work with the CDC, project goals, and future directions. So in 2021, ACPM was awarded funding from the CDC through a 5-year co-op agreement to disseminate the CDC's Let's Stop HIV Together campaign to our membership of preventive medicine physicians and subsequently your patients who are at risk for or have HIV. Through partnerships, member communications, cross-collaboration, digital communications, ACPM is able to disseminate the CDC's campaign materials across our channels. So we are currently in year 3 of this 5-year-long cooperative agreement. It's designed to amplify the CDC's Let's Stop HIV Together campaign, and ACPM is most focused on activating our physicians in an effort to decrease, new HIV infections, particularly among minority populations. Following a successful all-partner meeting in June, ACPM is turning its focus now to develop strategic partnerships to broaden the reach of this campaign. So through things like HIV ambassadors, leveraging our Prevention Alliance partners, ACPM has broadened its reach to give our physicians current campaign materials to promote to their audiences. And because we are, of course, a network of preventive medicine physicians, the content is specific to our providers on topics of stigma, testing, PEP and PrEP, patient-centered care, and much more. So in project year 3, we're working towards more effective strategies to engage existing and new partnerships and make this work visible and impactful. We're continuing to use our social media channels, of course, old and new members, partnerships, and all of that to our advantage. For example, we've now hosted 2 Twitter chat lives with the National Hispanic Medical Association. Actually, one is ongoing right now. So you can pop over to our Twitter channel right after this chat to look at some of the engagement that we've had with other PACT members. And then, of course, in the newsletters, we highlight campaign materials and link to all of the CDC Nexus materials that they have for our physicians to use. So as I close, as always, we continue to post on our social media channels, so please share, comment, and react to these posts so that other physicians are able to see the content. And our social media channels is where we do have the most direct contact with our members. So there are many preventive medicine physicians working in the HIV space, whether that's research, prevention, LGBTQ health clinics, testing sites, you name it, we're there. So they're our central audience in this, and we want our physicians to feel empowered by this Together campaign, use the materials and resources to your advantage, and ultimately serve your own patient populations who are affected by HIV. So thank you so much all for being here, and I'll hand it back to you, Donna, to introduce our speakers.
Thank you, Mira, and thank you again for all the work that you do to advance this important work under our funding with the Centers for Disease Control. So we have 2 speakers today that are going to share and showcase their work. And I'm so excited to hear from 2 of our members, Dr. Sandra Guerra and Dr. Richard Bruno. I'll introduce each of them, and then they will go in order of sharing their work that they've been doing, both at the community as well as at the health system level. And so Dr. Guerra was named the Chief Medical Officer of the Texas Health Action in June of 2022. She has more than 20 years of experience in population health care, serving patients of diverse backgrounds. She has served on the Board of Regents of the American College of Preventive Medicine, the American Board of Preventive Medicine on their exam committee, and the San Antonio AIDS Foundation Board of Directors, among many others. As a former secretary of the college, Dr. Guerra has been a long-serving member of the American College of Preventive Medicine. Dr. Richard Bruno is a current member of the Board of Regents at ACPM and is considered a hybrid doctor, double-boarded in both family medicine and preventive medicine, focused on providing excellent primary care while working on public health interventions in the community. Dr. Bruno is active in dozens of community-based organizations to help build collective power and improve community health. His career spans numerous clinical, academic, and research positions. He has served as the Senior Medical Director of Primary Care at Central City Concern in Portland, Oregon, and recently was named as the new Public Health Officer for Multnomah County in Oregon. And as I mentioned, he currently serves on the ACPM board. So we have two regents, past and current, that are going to be sharing and showcasing their work. So Dr. Guerra, why don't you go ahead and kick it off?
Thank you so much, Donna, and thank you for your kind words. I'm going to go ahead and start sharing my screen, so give me just a second here. And hopefully you can see that. Can someone tell me if they can see it?
Yes, we can see it.
Yes.
Great. All right. Well, good afternoon, everyone. My name is Dr. Sandra Guerra, and thank you for the introduction, Donna. And I'm very excited to be able to talk a little bit about what my experience has been working in a nonprofit organization in Texas. So put all those words together and you can see the challenges in it is inherent. Nonprofit, Texas, you name it, we've got our challenges. And so I want to make sure that at least I'm able to touch on some of these things. Let me see if I can start the slideshow. I think it's thinking. Here we go. So I work for an organization called Texas Health Action. It operates clinics in several cities. I'll talk about that in just a second. Texas Health Action is a community-informed nonprofit organization dedicated to providing access to culturally affirming quality healthcare services in a safe, supported environment with an expertise in serving LGBTQIA people as well as those impacted by HIV. So we are absolutely focused on prevention, but also treatment and everything that entails. So here is the way our kind clinics, which are affiliated and owned by Texas Health Action, are structured, just so you have a premise as far as the experiences I'm coming from. We have 4 locations, brick and mortar locations, 2 in Austin, 1 in San Antonio, 1 in Dallas. And then we do virtual care statewide. So both within the Kind Clinic and another platform called Telekind that also provides all the services that I'm about to describe. We also have Waterloo Counseling Center, and we have a community outreach program that has also a walk-in clinic where people can come in unscheduled to receive STI and HIV testing and treatment, as well as going out into the community. Our focus has really been around HIV prevention as much as we can, and all that entails, including addressing people's sexual health needs, STI evaluation, STI treatment. As we know, those left undiagnosed can actually increase a person's risk of HIV. We also provide services to improve the trust of our population in us as healthcare providers so that they do ultimately engage in preventive services such as PrEP. When we do find someone who is diagnosed with HIV, whether in the community or a walk-in area, because of our testing, we're actually able to get most persons into one of our clinics for their start of medication and treatment and evaluation within 24 to 72 hours. So it is pretty significant that we're able to get people in fairly quickly.
Dr. Guerra,
yes.
Apologies for interrupting. There's I believe you're in presentation mode, and there's a message from PowerPoint that is showing up on top of the slides.
Okay, I thought only I could see it. There we go. Is it gone?
Yes, thank you.
Sure, no problem. Thank you for letting me know. In Austin, where this clinic got started, and by the way, the organization got started because of a primary care physician 10 years ago who felt that PrEP was not being offered, particularly to the LGBTQ community. So she started offering it, and this clinic and an entire organization was born of that. In Austin, there have been some studies around quality of life for our LGBTQ community, and I want to highlight a couple of things because it's important in my presentation. That there is a significant mistrust of the medical community. You and I, many of us, our fellow brothers and sisters within the House of Medicine are mistrusted by the LGBTQ community. Many of these persons have received what I call medical trauma because of several aspects of their life or their physical being have been judged, stigmatized, and made to feel lesser than in the healthcare community. And therefore, their ability to access healthcare when they need it, and even less so when they need to prevent something, is much less than the general population. So I'm going to jump right in and talk about some of the challenges in HIV prevention in particular. Well, as I just mentioned, there is bias from providers across the board when it comes to patients who would benefit from PrEP, PEP, or STI testing and evaluation. Even a cisgender, heterosexual, female person who's coming in because they are pregnant are most likely to be assumed to be monogamous with the person who has impregnated them and is also purely heterosexual and in a committed relationship. And therefore, STI, HIV, and other things are put to the side as an area of concern. And we really need to improve that. As many of you have probably been aware, our syphilis numbers, our syphilis surges across the country are phenomenal. And therefore, we're seeing more babies being born with congenital syphilis because it's not being addressed. So therefore, that should be a red flag that something is going on, and it's not necessarily the fault of the patients, but we as a healthcare community really need to look at ourselves and see how we are playing into that factor. We recognize that monitoring someone who is on PrEP, oral medication in particular, which they have to take every day, is a time-consuming process for any practice. So many practices choose to not partake in it, even though it can be literally life-saving for patients. They recognize and they see that they have to talk to the patient, test the patient for HIV every 3 months. Now, I want to compare that to something we all have probably been familiar with all of our career, and that has been someone who needs to be on oral contraceptives in order to prevent pregnancy. That person is seen once a year. For someone who is on PrEP, they have to be seen and tested for HIV every 3 months. So you can see how there is a significant disparity sort of built into the business of prevention of HIV. HIV management, when someone is positive, will still be referred out. So that means persons that are HIV positive have yet another barrier to jump through in order to get into care and to be able to manage their, so imagine if we did that with every new diabetic patient, every new hypertensive patient, that we wouldn't even start medication until they were seen by a specialist. We would find that to be intolerable, but yet in HIV, we find it to be okay. U equals U is still a concept that is foreign to most of the healthcare setting, meaning that if you're undetectable, you're untransmittable, and that is the goal, is something that our medical community hasn't really been taught about very effectively. PEP, meaning post-exposure prophylaxis, is difficult to access by primary care and others. If I was potentially exposed to HIV in a manner that was not workplace related. that is very difficult for patients to access. So most of the time that care is being done in an emergency room or an urgent care setting. And they are not ideal settings to convert someone from post-exposure prophylaxis to prevention whenever that is indicated and needed. There is still judgment and shame for persons' sexual practices, and it is still prevalent in the medical community. So the idea that someone's personal choices when they are sexually active increase their likelihood of becoming infected with an STI or HIV is somehow something to place shame on. If we look at the data, what we actually see is that most persons who acquire an STI are going to be under the age of 40. And the reason for that is they are having sex with other persons who are also under the age of 40. The transmission is much more likely because of the pool of STIs in that age population. It is not something because of a choice that that patient made. So we have to be real cognizant of that to be in a judgment-free zone when we are speaking to persons, the same way we would be if someone acquired a cold or someone acquired a skin infection. We also are seeing in the medical community a significant amount of HIV provider burnout. And even though the entire medical community has seen that, in this part, it has been even more significant for a variety of changes. And we are also not doing a lot of good job in training people to become HIV providers. There are a lot of social determinants of health that go into effect here, but some of the ones I want to really highlight is that we realize even though the HIV diagnostic numbers are decreasing in the United States, yay, that is a good thing, at least for now, I am concerned that we're seeing syphilis numbers and other STI numbers going up. And so therefore we know that HIV is a lagging indicator of behind those. So even though the HIV numbers are going down, there's a very good likelihood they will go up again in the near future. But those persons who are being diagnosed with HIV, we have challenges in managing them because of a significant amount of mental health issues, substance abuse issues, and housing instability in that population. People living with HIV are now able to get quite a bit older, and therefore we have aging concerns when it comes to persons living with HIV. And I can tell you we're definitely seeing that in our clinic. So it's a great thing that this is no longer a fatal diagnosis, but in the same time, it is always a comorbidity that has to be taken into account, no matter what it is that is being treated as you get older. The cost of care for persons who are either living with HIV or trying to access preventive services is a significant barrier, even for those who have health insurance, and that is because of co-payments and other things. But I really want to focus on these racial and ethnic disparities that we're seeing in PrEP usage. And so you can see only 13% of Black or African American persons and 24% of Latino or Hispanic people who are eligible for PrEP are prescribed it, compared to 94% of the white people who are eligible. To me, that is extremely striking and very telling of the challenges that we have in trying to get prevention into our communities where it significantly matters. We also have seen a significant change in public health and funding. So the 340B organizations, such as ours, who provide HIV and STI care, have had a significant reduction in our funding over the last 3 years just because of some changes from the pharmaceutical industries. And we don't anticipate that that's ever going to come back or that it's going to change. We also have seen the political climate in where some states have imposed some limitations on how public dollars can be used for HIV prevention, STI, or LGBT care. And then we're seeing some legal challenges to the 340B program in general and the Affordable Care Act that we have to be on guard recognizing the stability of those funds may be limited in the future. We have seen a crumbling infrastructure for STI and communicable disease funding coming from the federal government all the way on down. And so we know that this is going to be impactful to all these organizations as well. So in summary, HIV prevention should be a standard of care for all patients, regardless of their life situation. We should treat the HIV prevention the way we would the prevention of flu or the prevention of any other health ailment that we have a mechanism to be able to help patients avoid. Elimination of health disparities is needed in our healthcare to truly have an impact on outcomes, including LGBTQIA individuals. Healthcare infrastructure is important. As probably many of you have heard, we had an Mpox outbreak issue across the world, and those that responded most readily within the United States were organizations such as ours that are focused on HIV prevention and STI evaluation and treatment. We continue to see Mpox in our communities. It has not gone away. We have a vaccination. All of this work was added overnight to our organizations with zero additional funding in order to make these things happen. And it continues to today. We need a sustained financial investment in our community for HIV and STI testing and treatment and prevention. That's my presentation. I'm going to stop sharing. Thank you.
Excellent, excellent, Dr. Guerra. So Dr. Richard Bruno, I think we'll take questions at the end as we have discussions. So we'll go straight into your presentation, Dr. Bruno.
Oh, great. Thank you so much, Donna. And thank you, Dr. Guerra. That was a wonderful presentation. I'm so impressed, and goodness, you're doing incredible work in Texas. So thank you so much for sharing. I wanted to tell you a little bit about what we're doing in Oregon as well. I'm a primary care and preventive medicine doc here in Portland. And today is my last day at Central City Concern, which is a healthcare for the homeless organization. And I'll, like Donna said, be moving to the Multnomah County Health Department to work on sort of larger scale public health interventions in the community here of about 800,000 people in the greater Portland metro area. So I just want to say I don't have any financial interests or relationships to disclose. I am a AHIB certified specialist through the American Academy of HIV Medicine. So I think we can we've kind of gone through some of these numbers a little bit already. You know, we have seen a little bit of a decrease in incidence from 2016 to 2019 in new HIV diagnoses, which is great. You know, some of these interventions are working, and we're going to talk a little bit about how that's going. As you see there in the graph from the CDC, you know, as the medications really started becoming more accessible, deaths decreased, but the prevalence has remained and grows as people are living with HIV later in their life. I want to also give another kind of shout out about, you know, special populations. Dr. Guerra mentioned a lot of folks who are disproportionately affected by HIV burden in our country, and some folks who inject drugs potentially, up to about a third of them have shared syringes regularly or occasionally. And this is something that I just kind of got from one of my predecessors at the health department. I was kind of asking, you know, there's some like regional differences in HIV prevalence. You know, I trained in Baltimore City where there was about 10,000 people living with HIV. And my clinic, Chase Brexton, we took care of about 4,000 of them. In Oregon, there's only about 7,000 people in the whole state of Oregon who are living with HIV. And I kind of asked her, you know, what do you think what's your theory here? And she thought that maybe it's the regional differences in the heroin. You know, the black tar more common on the West Coast, maybe kind of gum up the syringes more, and people just weren't sharing as much. Whereas the sort of more East Coast, either China white or white powder heroin, may not have done that. And you know, it's an interesting theory. You know, maybe we can discuss a little bit in our breakouts later. But I want to see how that landed with folks. Obviously, Dr. Guerra already mentioned sort of disproportionate affecting Black Americans, you know, who make up about 13% of the population in the U.S., but account for more than 42% of new HIV diagnoses and have the highest age-adjusted death rate due to HIV disease. Transgender individuals also about 3 times more likely than the general population to receive an HIV diagnosis, with an estimated 22% of transgender women who are currently living with HIV. That's based on survey data, a small population, but I think it is probably quite high. And then I take care of a lot of houseless people here in Portland, Oregon. And if somebody has been houseless in the last year, they're almost 2 times more likely to be living with HIV as well. Dr. Guerra already mentioned the ending an HIV epidemic and some of that, funding that's at risk there. U=U campaign. These are things we're trying to promote within our clinics. We have U=U stickers up in our team rooms and our waiting rooms, so we can prompt that discussion with people so that they know that, when you can get on treatment and reduce your viral load, you are untransmittable to others. And that's based on that study of about 1,600 serodiscordant heterosexual couplers over 10 years. And there wasn't a single transmission when they were fully suppressed. There's been some recent updates in some of the CDC prevention guidelines and the USPSTF recommendations. Just want to kind of highlight here the importance of asking all adolescents and adults about PrEP. That's a grade 3 recommendation. There's also some pretty good evidence that if people can't tolerate HIV medication or HIV PrEP, then cabotegravir is the new injectable every couple of months, can be very helpful for those folks who either can't tolerate oral meds or have chronic kidney disease and wouldn't be qualified for the other medications like Truvada, Descovy. And then HIV PrEP is recommended for folks who are at high risk. That's a grade A recommendation from USPSTF, and for those up to from age 15 to 65, screening for HIV is a grade A recommendation as well. There's also been some changes in the CDC guidance on monitoring. Dr. Guerra mentioned, how it can be kind of challenging and sometimes maybe a little bit inequitable to require people to come in every 3 months for testing, where we only require people who are getting contraceptives, yearly visits. I think that's a really important call out. One of the things that has been recently changed about the way we test those sort of general follow-up visits for people every 3 months is that we used to simply test like an HIV antigen antibody test as a way to make sure people hadn't seroconverted to HIV. But now there's been some suggestions that adding on an HIV viral load test also may be helpful, because maybe the PrEP medications may be masking an antibody response. So I think this is an interesting kind of nuance, just that sometimes we have to change our guidance. We have to sort of like get a little bit better at providing this kind of care for folks. In a primary care setting, we can see folks. We try to provide the care for people living with HIV on site at our clinics, and we train our providers to do that. Some of us are HIV certified specialists through the HIV Medicine Academy, and we really try to promote, regular cancer screenings for folks because of the risk of certain types of cancer that can get worse for folks living with HIV. Obviously, the cardiovascular risk is much higher in folks living with HIV. The importance of getting their immunizations regularly, kidney neurocognitive assessments are very important in this population, as well as smoking cessation and substance use disorder, as we kind of already hinted at earlier. We've been using various ways of identifying folks at high risk of developing HIV. We are converting to OCHIN Epic in the next couple of months at Central City Concern, but they do have an HIV Navigator sort of plugin that helps provide support for providers so that they can have certain tools for HIV mutation tracking and charting for those folks with high complexity. And there's been some really interesting AI developments around determining folks who are at higher risk of HIV. In the University of Florida is one, University of Massachusetts is another, using AI to sort of comb through the records and looking for social determinants of health that may predispose somebody, based on their charts that may be at higher risk, and then being able to target those folks with discussions about PrEP as a potential option to prevent it. I've been playing around with this images.ai website, and I just type in like a doctor and a patient looking at a laptop, and this is kind of what pops up. It's kind of a I don't know if they would actually be holding the laptop at the same time like that, but AI does some strange things. But I think it can be really helpful in situations like this. In our clinic, we have flyers up in our exam rooms. We have, are you interested in PrEP? PrEP may be right for you. And as you can see on the right, we have, if you're a gay or bisexual man, or if you're heterosexual, or if you inject drugs. So we kind of help try to folks with certain demographics gravitate to what they may benefit from being on PrEP. And so we try to promote it, we try to talk about it, we try to screen for it every encounter. And then we also have pharmacists embedded in our clinic who we can schedule them for a PrEP visit with the pharmacist who can monitor those labs, keep those refills going, and continue to see folks for PrEP specific visits. Outside the community, we're also doing work trying to ensure we're testing people in the community. I didn't have pictures of what we're doing exactly in Portland right now because we just got our mobile van started last month. But these are pictures from when I was out in Baltimore City working for Chase Brexton Healthcare in Baltimore City. And we had an HIV van. We would go out and we would test people once or twice a week and get people, rapid HIV testing and directly linked with care and treatment from our providers in our brick and mortar clinics. So I think that's a really important way of sort of, as I say, meeting people where they're at, making sure that people can get tested, know their status, and get plugged in with PrEP or HIV treatment. And there's some references, and then I think we're going to move on to some discussion here. So looking forward to that. Thank you so much for having me.
Oh my goodness. Thank you both so very much. What incredible presentations, and just, I've learned an incredible amount myself, and I'm certain that the audience that's been participating has as well. So thank you. Oregon and Texas are very fortunate to have leaders such as the two of you at the helm of doing such important work. So now it's time to hear from the full audience. As Dr. Bruno mentioned, this is now our time to hear from each of you and your thoughts. While there has been new HIV diagnoses, and we've made a lot of incredible progress, what you've heard from both Dr. Guerra and Dr. Bruno is there's still so much more work to be done, so much work that still needs to happen. And without intervention, there could be potentially another 400,000 more Americans diagnosed in the next 10 years with HIV. So we're going to break out into smaller discussions because I think we have about 30 people on the line here to give everyone an opportunity to speak, engage, and exchange. And we're going to break in these smaller group discussions to discuss the following question. What opportunities do you envision when you read the word intervention to drive equity in HIV prevention and treatment? So again, what opportunities do you envision when you read the word, quote, intervention to drive equity in HIV prevention and treatment? So back, I don't know about the other groups, but we certainly had a riveting conversation in our breakouts.
Well, if you had the new Multnomah County Health Officer there, you would have had a sensational conversation. I want to know where your desk is. You know where mine was. I was commissioner in Multnomah County. You didn't know that.
Yes, Dr. Tilson, I'm a big fan, and I would love to chat with you sometime, and maybe here's some stories.
I've got stories upon stories.
I love it. Yes, thank you. I appreciate that very much.
Including where they took the sculpture that was in the corner of my room that had been on the roof of the old building that they bought down by the railroad station. Maybe Don Rock still is alive and has it in his living room. I don't know, Rick, but we'll talk privately about that. Many happy memories. Congratulations. They've chosen well.
Thank you so much. Appreciate it.
These are the types of exchanges that these meetings actually bring forward that just truly warm my heart. So hopefully, as I mentioned, each of you had an incredible, rich discussion. So I'm eager to hear the report outs. So I know our group actually had a report out person assigned. I don't know if Dr. Lane, you would like to go first, and then we'll go around, and Melissa and Eric. Melissa, and who was the other? Mira. We'll hear from each of your groups. Dr. Lane, you're on mute.
Still on mute, Dory. There you go.
Okay, I say my best things. I hate to say my best things when I'm on mute. But anyway, we did have a lively discussion about opportunities now. And one of the things that was mentioned is that to some degree, many are locked into the old view of AIDS, HIV, when it was a pandemic and disease focused, and we sort of need to rethink about the disease now, where it's preventable and it's bringing it more into our bailiwick for some degree, in terms of being one of the things that we can hit on and feel responsible for in terms of addressing it. So, and thinking about venues where this might come up, Boris was talking about the, in terms of being at a school of public health, making sure students are aware of HIV prevention and what needs to be done. And we're talking about, the various places that people in our specialty work and possibly developing a lot, utilizing the materials or the approaches that Sandra and Richard talked about, making them more widely known, perhaps by developing, handbooks like how to improve your impact in terms of, or intervene in terms of HIV when you're practicing in this kind of setting, let's say in an FQHC. Some may be working within health departments. The question is whether, like the communicable disease divisions, STI component, whether they are doing anything, focused on the prevention side in terms of PrEP and spreading the word. We really, like many areas, one of the first interventions you have to do is heighten awareness, get the word out. And so I don't know if I covered everything we talked about, but Donna and Boris, do you want to add anything?
The one thing I would add, and then Boris, please, is my biggest takeaway from hearing the two of you speak profoundly, as always, was that ACPM really has an opportunity as preventive medicine physicians to be kind of on the cutting edge of showcasing that HIV is in the space of prevention, and it really truly is in the preventive medicine lane. And building on the incredible presentations that both Drs. Guerra and Bruno provided, we could probably capture and sell an HIV course to all primary care physicians to help them overcome and understand. And so it really might be a real sweet spot for ACPM. So that was one of my biggest takeaways that I'm so excited about, seeing how we can pull that through. Dr. Lushniak, did you have anything else that you wanted to?
I think that's a good point. The point I think we had made is that we've I brought up the issue that, when HIV first came out, right, we were in a shocked phase in medicine, right? Young people were dying. We were trying to figure out what was this brand new disease. And in this generation, we've gotten used to it, haven't we? Right? It exists. It's not curable, but it's been treatable, people. And I think it behooves us to basically not give up on this, not to say this is good enough, because we realize it is preventable, right? It's almost like our attitude towards it has become almost to some extent like, our attitude towards cigarette smoking. Well, we've done so much already. We're down to the, almost single digits, 11%, 10% of the population. It's okay. But no, 460,000 people are still dying every year. So we can't give up on smoking, even though we've made incredible progress. Here's another example of that.
Okay. Melissa, do you want to have your team go?
Certainly. I was with Dr. Bruno and Andrea Serafin and Dr. Alexander. So Dr. Bruno has offered to report out on the group's discussion.
Thanks, Melissa. Yeah, we had a great discussion. I had sort of initially framed it in the way I sort of conceptualize primary, secondary, and tertiary prevention of HIV. I steal the cliff analogy from Dr. Camara Jones, one of our Prep Med docs, and she talks about how people kind of get pushed to the edge of the cliff and then kind of fall off, or they would seroconvert into HIV, and then what we can do at the bottom, like to help people who are living with HIV be more healthy. So I really like the thinking about how we can decrease, what were the large scale interventions we can do to prevent HIV transmission and prevent people from getting pushed, to the edge of that cliff. In the middle, we have, PrEP, screening people, number one, like PrEP, and also needle exchanges for places of high IV drug use and regionally. And then at the bottom is getting people rapidly started on HIV treatment to prevent opportunistic infections and those low CD4 counts. So, that's kind of how I think about where we can kind of stratify. And we talked about stigma being a big barrier for a lot of folks to not only sort of getting tested in the first place, but also to even taking their daily medication, right? Because I can tell you, working in Baltimore, it was a big challenge with adherence. People would pick up their pill bottle and look at that HIV medicine, would remind them that they had HIV, and they wouldn't take it. It's I don't want to think about the fact that I have HIV today. And so we maybe go months without seeing people, and then they come back, and then we if they wanted to restart, we'd have to actually do a genotype test to make sure they didn't have developed any resistance first before I could even restart them on a medication again, so that can be a real challenge because you're waiting a week or two sometimes before you can actually even restart people. So we talked about how we're all very excited about this new injectable treatment for not only PrEP, with Apretude is the cabotegravir, but there's also cabotegravir with rilpivirine that is going to be every 2-month injection. So someone can come in and get PrEP or treated for HIV without having to remember to take a pill every day and adhere to a daily pill regimen. So I think we've come a long way with making pills better and less side effects and 1 pill a day and that kind of thing, but it's still maybe not enough. I think that we should really kind of help explore how well we can integrate injectables into primary care practice. And I think most primary care docs, like Donna said, could be trained to do this kind of work. We can really help facilitate people taking on their own panel and not having to send somebody off to an HIV specialist or infectious disease specialist. I'd say most people can be taken care of in a primary care setting. It's the folks who have very severe disease or very high resistance patterns that make very challenging, complex drug regimens would be the ones that I would maybe consult on an infectious disease specialist on. But I say most primary care should be able to take care of folks within in-house. And I think we think that those kind of interventions and promoting that in primary care clinics is a really important place to go.
Excellent. Mira, or any reactions from anyone else on your team, Melissa, or any feedback from others? Hearing none. Thank you, Dr. Bruno. Mira, who is going to be your reporting out from your breakout?
Yeah, we were in a breakout room with Dr. Guerra, Tilson, and Harmon, and Dr. Guerra is going to take it away.
Okay, thank you.
So we had a very, I think, similar conversation that was probably had in the others. Dr. Bruno, we completely agreed and talked about wanting to make sure that the college really does accept and move forward the idea of mainstreaming everything around PrEP, PEP, and of course, HIV care as well. And we recognize that there's a lot of challenges regarding that, but we do feel that that is really within our scope and our ability to start really ringing the bell on and trying to make sure that we have everywhere through the process the ability to mainstream this, including talking about sexuality and wanting that conversation to start med school and as well as in residency and throughout training for those that are already in practice, giving the opportunity for refresher or teaching around that. And so I personally would think this would be a very interesting topic to have at one of our annual conferences at some point, or track, really to talk about human sexuality and all the health implications that come into that. Because I do think it's a really an interesting area that prevention can really play a role in and help to destigmatize everything that we all recognize is attributing to medical trauma and challenges for patients out there. One of the other things we talked about is how there's even additional layers of disparities within the services that need to be provided for persons to prevent HIV. And that often includes LGBTQ care or let's say trans care in particular is an area that we talked about. Trans care in particular is an avenue that at least our organization steps into to provide gender affirming care in order to increase trust from the trans community, where almost 50% of persons that are in the trans community end up acquiring HIV. So we really do need to build a trust and rapport in order to encourage them to be able to take PrEP. One of the things none of us have really talked about here that I think is kind of intriguing and interesting is DoxyPEP, which is to prevent STIs by someone taking doxycycline after they have sex. And the initial studies have really demonstrated some pretty impressive numbers of 70%, almost 80% reduction in actually ever testing positive for an STI after a unprotected sexual encounter if you take doxycycline, which is really interesting, but yet another step in prevention of STIs. And I think that that's really exciting, and another area that if the college really takes a stand on it and tries to be the leader in educating around this, we could really be impactful. And I think that's really what our group was talking about is what can we impact? And we think this is one of the things we can. Those in my group, if anybody else has anything else I forgot to mention, please chime it in.
Well, I think we had, oops. Is somebody trying to speak? Go ahead, Miriam.
Yeah,
Dr.
so I wanted to just make a comment, and we didn't really talk about what the college could do, but in thinking about it and thinking a little bit about one of the points that I had added to the group that I was in with Melissa and Richard, I think one of the roles the college could play that nobody else is really playing is we're really all thinking about this on an individual level and thinking about how do we try to prevent in individuals. And what we're not thinking about too much is disease burden in the population. And the reality is that if we can reduce the burden in the population, we reduce the risk of anybody getting infected. And maybe, when you think about better financial coverage of medications or getting it into primary care locations or destigmatization or every 2-month immunization, 2 shots. What we're really trying to do is reduce disease burden. Yes, we are trying to obviously make it easier for any individual, but we're trying to reduce the disease burden, the prevalence. And so that is a role the college could play because that is our niche, sort of a population approach. So, that is a unique approach we could take.
Absolutely. Thank you for that. Dr. Tilson, I see your hand up.
First of all, I wanted to say how wonderful it is to be on the same call with you, Miriam, Alexander, Dory. This is definitely old home week. Wonderful to see you all. And I couldn't agree more strongly. I think that there are some things that the college can do that other medical practitioners and medical practices can't do, because we understand that medicine doesn't require definition of illness, doesn't require coming to a sickness place. And one of the things that we haven't talked about is wellness approach to these populations. That is to say, finding intervention places for intervention that aren't the clinic. Both of the examples we talked about were clinic-based. Both of them involved people whom we called patients. But basically, if you want PEP and PrEP, you're talking about healthy, swinging young people who don't define themselves as sick and don't want anything to do with our healthcare system. And I don't blame them. I mean, and they know they're going to get stigmatized if they do, or they're going to get into a database and some politician is going to find out that they're trans. I mean, so are there some things that we can do to get access, particularly to PEP and PrEP, out in the wellness community? Where do healthy people who are substance users or having active sexual contact that may be risky find themselves that are not clinical, but that could have PEP and PrEP? Well, one is the drugstore. So I think pharmacy may be a more natural partner than perhaps we have looked at as just a place to go. This is old think, of course, as well as new think. I can promise you, my generation looked at pharmacies as the place you went for condoms. And you bet we didn't say you need to come into my clinic to get a condom. We got them out into the sick rooms or the nurses' room, because people did define these things as personal in schools, for example. So maybe school health is a way for us as preventive medicine people, again, to align with the wellness community, just taking Miriam's suggestion and going even further into things that are not clinical at all. And I agree with, of course, the sexuality comment you can bet came out of me, because I think everyone who's heard me on one of these calls before knows that I was the first generation in medical school that had Bill Masters of Masters and Johnson teaching our sexuality class to medical students. And boy, did that ever change my life. I mean, that's right. We need to look at this as wellness behavior, not sick behavior, and not having anything to do with the clinic.
Yeah, really good points, Dr. Tilson. I think location is super important, and pharmacies are like a really good place to be able to get this done. There's been bills in Maryland brought by one of our PrepMed members and fellows, Clarence Lamb, trying to expand access to pharmacists being able to prescribe PrEP for people. I think that's really important. School-based care, absolutely important. Students should be able to get and talk about their sexual health with a trusted medical professional, without having to get their parents involved in that type of care. And then a lot of young folks are turning to online PrEP care these days. There's a website called Mistr, MISTR.com. They can provide PrEP for people, online. You would go to like sort of like a local lab, or I think they even have like a home kit. You can test yourself, send in your results. They can get you the medication that way. So
the question is, will you as a county health officer have access to the information systems that gets that has you facilitate that kind of access, so they don't have to come to you? You just get the word out. Here's where you can go to get non-judgmental services when you're healthy. But that's just there's a challenge for you starting next week.
Fair.
Monday, I think. Monday, right?
Oh, I'm going to start in January, so I get the month of December off to be with family. But yeah, little breather here. Yeah.
But we may have a conversation before you even start.
Yes,
anyway,
that'd be great.
You will also, in Multnomah County, you're also inheriting a legacy. Multnomah County, I think, was the first that took HIV screening out into the gay steam baths. Every Friday night, we actually went into the baths and just had a non-judgmental room. If you were worried and wanted to get a Calci swab, you could come in and we'd swab you. No questions asked. All we had to do was get a number, and then you could call and with your number and get the results. That got all of these concerns about stigma or privacy or being found out. I mean, we had a great conversation. Boy, Dr. Guerra is really a hot ticket. She's all over these issues. Great conversation about privacy and the fact that if you come into a clinic, you get a record, and nobody wants a record. They don't want a record of all this.
Are there any other questions that any of you may have of Dr. Guerra or Dr. Bruno based on their presentations before we start wrapping up and offering some closing remarks? I just wanted to make sure that there would be an opportunity as well for any questions that anyone might have, because those presentations were just so spot on and so full of rich content. Okay. So say if so, please raise your hand, take yourself off mute, or go ahead and ask the question. Seeing no hands, I just want to again thank each and every one of you for taking the time out of your busy days to be with us, to spend some time with us, to reconnect with past presidents, other leaders of the college, our regents, and our speakers. It's been such a great opportunity to be together and to really set the stage for how we as the college might be able to collectively address the opportunities that are ahead of us, and to really engage with our Prevention Alliance members. I think we have a lot on this platform to advance, and I look forward to following up with Drs. Guerra and Bruno to see how we might be able to develop the right course that we could actually package and sell to primary care and really put a stake in the ground for how preventive medicine physicians can advance and to normalize and mainstream, to using your words, Dr. Guerra, PrEP, PEP, and then HIV prevention. So we look forward to seeing you at our next meeting, and we look forward to seeing you during Preventive Medicine 2024 in Washington, D.C., April 18th to the 21st. If we don't see you sooner than that, some of you will see on a board meeting, and some of you will see in other gatherings between now and then. But again, thank you again for joining us. Thank you, Melissa and the entire team, Mira for your presentation, Eric for helping, and Melissa for pulling this all together. Truly appreciate the collaborative teamwork. And then again, to our incredible speakers, Dr. Guerra and Bruno. Thank you for joining us as we wind down 2023, and we're looking forward to jumpstarting into 2024. So great seeing everyone. Thank you all so very much. Have a wonderful afternoon.